So again, I'm the lead physician of the Menopause Midlife Clinic here in Boston. I am board certified in internal medicine, and actually I started my career in OBGYN because I always wanted to take care of women. But I found that my skills lied in counseling and discussing risks and benefits of lifestyle and supplements and medications and all types of ways to manage chronic condition in women's health. After I finished my internal medicine residency at Case Western, I went on to do fellowship training in advanced women's health at the Cleveland Clinic, and it was there that I became so interested in midlife and menopausal health. And I've been practicing consultative menopause for many years, and there is certainly hope and solutions for anyone and everyone who needs them. So let me tell you my story on how I became a menopause doctor. I certainly didn't go to medical school thinking I was going to be a menopause doctor. But as I alluded to, I always wanted to take care of women in crucial times in their life. And it turns out that my skills didn't lie in surgery, but much more in consulting and discussing ideas about women's health and helping women create a priority for themselves and determining their long-term health. So during my fellowship training, I was surprised to see that women from across the globe would fly to Cleveland to get help in menopause and to determine what was the best treatment for them based on their unique medical, surgical, and obstetrical history. And I just realized it was the biggest gap in care for women's health. And I see patients for all different types of menopause, as we're going to get into. So, let's start by discussing some of the seemingly obvious questions and answers. What is menopause? Well, we use words interchangeably to determine or to speak about menopause, but menopause is when a woman has had no periods in 12 months. And after that 12 months, you can say, I am in menopause. Or another thing to say is, I am now post-menopausal. And after your last menstrual period, once you're postmenopausal, you are always postmenopausal. When you go through your menopause, your ovaries, which makes estrogen from the follicles that become eggs, pretty much retire. So you don't have any follicles or eggs any longer. Because you don't have any follicles and eggs, your estrogen levels drop to nearly zero after menopause. And your FSH, or another way to say this is your follicle stimulating hormone level, that's what FSH stands for, it gets really high when you are postmenopausal. And certainly your body will change in response to these anatomic and physiologic changes. And the anatomic changes, meaning those changes at the level of the ovaries, and physiologic changes, meaning the loss of estrogen, as well as testosterone in your body. So by the textbook, and not all women follow the textbook, menopause is 12 months of no periods, lab work showing high FSH and low estrogen, and classic symptoms. So what are classic symptoms? Well, there's actually many symptoms of menopause. And I should also say that classic menopausal symptoms can also start in perimenopause. And perimenopause is the time leading up to menopause, typically where periods can become a little irregular, but symptoms can also start at the time. So 75% of women will experience hot flashes, vaginal dryness, which leads to painful intercourse, brain fog, which could be anything from trouble with memory or recall, or just feeling like not like yourself in your ability to complete tasks. Fatigue, exhaustion are common. Disrupted sleep, new onset of insomnia is really common. Mood changes such as anxiety, depression, and irritability are very common. And metabolic changes like weight gain, or you may have heard people talk about the menobelly, or breasts can change, or you might not even actually gain weight, but you feel as though the weight is distributed differently. So the definitions of menopause, menopause in the United States, the average age is 51 and a half, although I see women of all different ages. Early menopause is if menopause is between ages 40 and 45, and premature menopause is if your menopause is before age 40. And a lot of times we see this in women who are undergoing chemotherapy for any type of cancers or risk reducing surgery where ovaries are removed to reduce the risk of ovarian cancer, or other types of indications that are not related to cancer. And certainly surgical menopause, if you remove both ovaries, can happen at any time, not just to reduce your risk, but perhaps you had a cyst or you had an emergency surgery and both your ovaries were removed. Sometimes women don't know what it has been removed at the time, which could be your uterus, one or both of your ovaries, and your cervix. So it is helpful to know if you have had gynecologic surgery, what was removed. And then again, perimenopause is the time leading up to menopause in which you can still have symptoms of menopause and can last on average 1 to 10 years, but more commonly a few years. And the average onset age of perimenopause in the United States is 47. So there are some really important misconceptions. And the first is this idea that symptoms last for this 1 year and then they go away. Well, symptoms last on average 5 to 7 years. 10% of women never experience any types of symptoms. And that's great for them, but it does not mean that your body doesn't change. Your body still changes in response to the loss of estrogen. You just don't feel anything. And 10% of women have symptoms that last forever. And once you're postmenopausal, you'll always postmenopausal. Remember that. And your estrogen levels remain low for life. For many women, menopausal symptoms can be quite severe. And research says that a quarter of women who have symptoms, again, which is about 75% of women, for a quarter of those women, the way that menopause affects them is significantly and severely. And it can affect you, your personal life, your job, your ability to function with family and friends, to be intimate with your partner, and to feel good about yourself. So it is really important to feel as though you have a safe space to discuss your symptoms and what you might need to ensure that you have a really good quality of life. So what are the options for lifestyle? Well, there's two things that have been shown to have proven benefit in randomized controlled trials, which are the big studies where they compare two groups of women, those types of women who will go through the intervention and women in the control group. And the biggest benefit that's been shown in terms of lifestyle and reducing menopausal symptoms is cognitive behavioral therapy, or CBT for short. And the second one is hypnosis. Now, in cognitive behavioral therapy, you are doing things that tell your body that feel better, and over time, learning those skills to cope with the onset of symptoms. Sometimes people do this with a therapist or start with a therapist and then learn the coping skills and continue to do them on their own. Some people learn to do cognitive behavioral therapy without knowing that's what they're actually doing. So a good example would be slow, deep breaths when a hot flash is about to come on. That could be taught to you through cognitive behavioral therapy, and you could discuss with a trained provider what mechanisms work better for you. Or you could just realize at home that slow, deep breaths and meditating and being mindful help reduce the severity or the frequency of your symptoms. So that's just one example of cognitive behavioral therapy. Basically, for short, it's realizing what lifestyle methods help you to reduce your symptoms. And that could be meditating or anything that usually brings down your nervous system from firing. So things that are calming. It could be closing your eyes, deep breaths, meditating, drinking a warm glass of milk, drinking tea, laying down for a few minutes. Those can all be examples. And also hypnosis has been shown to have some benefit. However, I have never sent anyone for hypnosis because it's just not something that's readily available. So that's more for your fun fact knowledge. Now, things that definitely can't hurt but don't have clear uh, scientific benefit in randomized controlled trials are things like exercise, yoga, over-the-counter supplements and herbals, acupuncture, and chiropractic interventions. Now, you'd think that all these things would be no-brainers, that they would certainly help improve symptoms, but not always. And there's many reasons why. And it's my suspicion that most of the symptoms we have are actually genetic or familial, and that there are just certain times when, even if we do all of the right things, we're still going to have those hot flashes, or we're not going to be able to fall asleep. Certainly, you can't exercise your way out of painful intercourse. And so, all of these things on this list here, exercise, yoga, acupuncture, and chiropractic interventions, if those are helpful for you, then good. You found what works for you. But if it doesn't work for you, also don't be surprised. Now, over-the-counter supplements and herbals are a topic where I think it's really important to tell your clinician what you are taking, what you are trying, to be sure that it's safe with your medical history. Oftentimes it is, but it is always nice to have a dialogue and let your providers know what it is that you're trying. And if it's working, it's also a signal that you might be having really severe symptoms that perhaps require different types of treatments. Now, vitamins are certainly a great enhancement to lifestyle in midlife. And the ones that I recommend for most women in midlife are this following list. Vitamin D, 1,000 to 2,000 international units a day. Calcium, 1,200 milligrams a day. Best to actually get from foods, and really only supplement if you don't eat any calcium in your diet. Magnesium is great at bedtime if you have slow transit constipation, migraines or headaches, or trouble falling asleep. And on the topic of migraines, B2 is a great option. B6 is a great vitamin for swelling or edema. And CoQ10 is a great supplement to take to help reduce joint aches and pains if you take a statin medication. Now, there are non-hormonal options to help treat hot flashes. And there is one FDA-approved option, which is named Brisdel. Brisdel is the brand name, and the generic name is paroxetine 7.5 milligrams. If that sounds familiar, that's because paroxetine 10 milligrams is sometimes used as well, especially as sometimes Brisdel can be costly, even though it's the only FDA-approved option to treat hot flashes. Other options that we use off-label to treat hot flashes are low-dose SSRIs and SNRIs like venlafaxine, which is Effexor, or citalopram, which is also known as Celexa, or escitalopram, also known as Lexapro, or gabapentin, which is actually in the nerve classification, clonidine, which is an antihypertensive, and oxybutynin, which is a medication for overactive bladder. They're all sometimes used to help manage hot flashes. Now, importantly, the SSRI class, which includes that medication Brisdel, cannot be used if you are using tamoxifen as chemoprophylaxis or to reduce your risk of breast cancer, because it can render the tamoxifen less effective. Now, this is something you can discuss with your healthcare providers to determine what's the best route and option for you depending on the severity of your symptoms. Now, there is a new medication being studied to treat hot flashes, and it's currently in phase 3 clinical trials, and it works differently than Brisdel, and it works to control core body temperature. This will be a really interesting option when it is completed its clinical trials and it's on the markets. My suspicion is it will be studied first in flashing but otherwise healthy volunteers before we look at its use in patients who are at high risk for breast cancer or for breast cancer survivors. And it's called a neurokinin 3 receptor antagonist. Now, hormone therapy is something that can be utilized if you are having severe symptoms and you do want to have a full discussion on the risks and benefits of using hormone therapy. This should be discussed in conjunction with all of your providers to determine the individually best choice for you. If you are at high risk, this does not mean that hormone therapy is not an option, but it should be individualized based on the severity of your symptoms, your health goals, and the priorities and how you see health for you. There are many different options of which we won't get into here, but if you are suffering significantly and not getting any relief from non-hormonal options, please consider discussing with your clinician if it's appropriate to discuss other options. Now, if you have a uterus, you will need to take progesterone, and oftentimes we also add estrogen to help with the symptoms of low estrogen. If you don't have a uterus, estrogen only is an option. There are many FDA-approved options, and only FDA-approved options, in my opinion, should be utilized, in contrast to compounded non-FDA-approved hormone therapy. I would be happy to have discussions on these risks and benefits with you. If we have tried non-hormonal options and you have still not gotten relief from severe symptoms. Now, vaginal estrogen has been shown to be extraordinarily safe because vaginal